admit that getting the opportunity to speak tonight means that the amount of time I put into this talk last fall is doubly paying off to me because of the fact it took quite a lot of time to get this together. These are my disclosures. The first one is very true. I'm an overworked rheumatologist because of the shortage of my specialty. I'm in private practice, so I'm professionally responsive only to my patients. I don't listen to the hospital system administrator or the medical director. And last, I'm an active advocate. I'm an advocate for my profession, I'm an advocate for my specialty, and I'm an advocate for my patients. This is what it was like when I started to put it together. I sort of felt like I was going against a hydra, and that every time I cut off a head, I found 2 or 3 more heads to go and attack. And that's because this is such a complex discussion. First, the question everyone asks, is there really a shortage? And I think this is showing some data related to this. This comes from an AAMC study. And in 2019, there was a 13,000 physician shortage for primary care physicians. And if you look at by 2034, there are expectations of anywhere from 17 to 48,000 too few primary care doctors, 30,000 surgical specialists, and then 13,000 of other medical specialists. And so this is a major problem when you talk that kind of numbers. When you look at how many doctors per capita, you can see here that the United States is way the heck down here at the very bottom. Only Korea and Mexico have fewer physicians per capita. And that's a big problem. We definitely have a shortage of physicians. And as the population grows every day, it seems, we are going to see it even get worse. Let's take a look at a little history, because I think looking at the history of this problem will give us a lot of information as to why this occurred. Back in the 1960s, there was a shortage of rural physicians. And at that point, they said we were reaching a crisis. And so there was this big rush of new medical schools, and they then were able to help solve it because a lot of the medical schools were set in smaller communities. Well, unfortunately, by the 1980s, the medical national advisory committees started to say that the U.S. was on the verge of a massive physician surplus. And of course, we all know what happened after that, because then we saw a curtailment of new medical schools. We saw a need to constrain the training of new physicians, and there was an institution on new medical schools entirely. And in fact, if you look, there were like almost 1,000 fewer medical students per year in 1989 compared to 1981. Well, what happens is, as we started to realize by 2006, there was a shortage, and that's when the AAMC said, oops, we made a mistake. We need a 30% increase in medical school graduates. If you look at the population growth and compare it to what they did, you can see back in the 1960s, there was a major shortage. So there was a big ramping up. But once 1980 went off, we saw this leveling off of the number of medical school graduates. Well, at the same time, the U.S. populations continued to grow. It wasn't until 2006 when the moratorium ended that we started to do it. And as you can see, there is an increase in the per capita number of medical students, but it's not catching up yet to where the population is. It could have been worse. One of the things that happened in the 1980s and 1990s was the start of osteopathic schools, or DO programs. And once this happened, we were able to help to reduce it to some degree, but it still has not totally resolved it. In our area, we've seen a lot of new medical schools between 2002 and 2019. There is an increase to 21,000 students per year in allopathic schools. The other thing we've seen is 17 new osteopathic schools. I can confirm on this. We have a new osteopathic school about 60 miles from us. There are several others in Southwest Virginia. And so this has been a very important step to helping to reduce the shortage of physicians in the United States. And as you can see here, they've done a really good job. In 1960, there were a total of 5,000 osteopathic medical schools, 13,000 physicians turned out a year. By 2018, that number had jumped up to 55 locations, 35 schools. And contrast that, there are 141 allopathic schools present. So this has really added a lot to the medical education in a hope that we can curtail the problem with the underserving. The one problem that we have not had a big step in the right direction with is residency spots. If you look at this study, it was done here, and we can see that there actually were, back in the late 1950s and 60s, there were actually more PGY positions than there were applicants, but that sort of flipped over between 1970 and 1980 when they did the moratorium. And what's happened is finally we've seen an increase in applicants, but the number of positions has not gone up at the same rate. One big problem about this is because of the fact that CMS has not increased the number of approved positions by these that can be covered by Medicare and Medicaid services. And because they've not increased that number, despite the fact that our US population has gone up big time, that's why we have a major shortage of physician training positions for residencies. If you look here, another problem in the shortage is that there's a maldistribution of doctors. In terms of primary cares, you can see that when you look at the northeastern United States, there are a lot more PCPs per 10,000 population. Contrast that to Tennessee, where it's 11 to 15, and down here in a lot of the southeastern United States, many of the states that are represented by the SMA, we can see there is a drastic shortage of primary care physicians per 10,000 population. And the problem, what we have is the big reason they're all up here in the Northeast is that's where a lot of the training programs are. I read somewhere that that 1 out of every 7 physicians is trained at some point in the state of New York. Well, unfortunately, that means that those people often stay in that area, and that's a big problem. So we aren't getting them down into the southeastern United States. I can speak from my own specialty because we know that there's a major rheumatology shortage. Right now, according to the ACR, there are about 1 rheumatologist for every 52,000 population nationwide. If you look at it, though, by region, you can see in the northeastern United States, there is about 1 rheumatologist for every 40,000 population. There is actually only 1 per 80,000 population in the southeastern United States. In southwestern U.S., outside of California, there is actually worse problems where there's 1 rheumatologist for every 87,000 people. An example of the maldistribution within my organization is just looking at my state versus Philadelphia, Pennsylvania. There are actually more members of my national organization in the city of Philadelphia than in the entire state of Tennessee. The state of Tennessee has a population that's 4 times that of the city of Philadelphia. And this is excluding people that live in Camden, New Jersey, or King of Prussia, Pennsylvania, or Valley Forge, where there are rheumatologists as well. And so the biggest problem is, if you look at residency training programs, unfortunately, when it comes to rheumatology, there are actually 4 in the city of Philadelphia, and each one's turning out 2 to 3 fellows a year. Contrast that to Tennessee, where there are 2 fellowship programs, and they together put out 3 people per year. So we've got a major shortage of people, and they're not being trained in the areas that need it the most. Another issue that's really had an effect on the shortage, unfortunately, is females in medicine. I have a partner who's a female. I have soon to have another associate joining us who are females. And I think it's wonderful that the number of females in training has gone up. And actually, over time, we have seen that by 2019, over half of the medical students are female. And I think that's a great thing because I think there are times when they can appreciate that they are far better at handling certain situations than their male counterparts. The problem occurs, though, is because of the fact of family on women. And what we've seen in this study, you can see here, came out from 2019. And what they looked at was how many physicians were working full-time versus part-time versus not working at all. And that's where the gender differences really stood out. What they noted was that 30% of the women were not working full-time versus 5% of the men. 70% of women working part-time were also, they did not, and what they did was they cited that was the family factors as the reason. And if you look at the number of doctors who are considering going part-time by gender, you can see that as many as 64% of the women in these studies were considering going part-time versus 19% of the men. And so it's a sad but truth that unfortunately, while the women are doing a great job that are practicing medicine, a lot of them don't want to work the full-time hours because of the fact that they want to have more family time, and they make some compromises in that situation. Another issue that's caused complications in the number of doctors we have is the earlier age of retirement. My father was literally died on the day of his, on the day he died, he had never retired. My father passed away at 80 years of age, and at 79, he was still coming in the office. This is not, I think, a thing of the past in many cases. If you look, the average age of retirement of family practitioners in 1980 was 70, and in 2016, it's dropped to under 65 years of age. I'm not that far off of retirement age, and I have to admit I'm sort of dismayed because I've seen a lot of people who arrived about the same time I did who have been announcing their retirement. I have 2 kids in college, so guess what? I have no desire and no plan to retire in the near future. One big problem we have, unfortunately, is the biggest problem of all is this: burnout. Burnout is one of the major factors when it comes to patients being, or doctors leaving their medical practices. I think this is one that also is under-identified as a real problem in healthcare right now. There was an interesting survey: 68%, 62% of all physicians over the December through January had had at least one manifestation of burnout. If you look at this over the years, we can see that 2010, it was less than 45%. So this is a pretty significant jump in the number of people who are practicing physicians that are complaining about having burnout and admitting to it. Some of the reasons are, first one, COVID. COVID has been a major factor in burnout. We have seen a lot of physicians who, when the COVID started to hit, they basically said they got pulled in for long hours and were underappreciated, and they actually decided enough's enough, it's time to quit. Another problem is decreased autonomy. There are more physicians now than ever that are employed than in private practice. And there's good studies that show that there is more burnout in employed physicians than there is in clinician-owned practices. One of the problems is we have increased administrative intervention. We all know that medical director or the CEO of the hospital system or whatever, who makes us check on a lot of administrative boxes, and that's more important to them than it is making time with our patients. In my specialty, one of the biggest ones is prior authorizations. We have, I've actually had a cartoon I saw and I lost it that showed the 4 horsemen of the apocalypse being ridden up with a 5th horse, and that was prior authorizations. Mandatory use of increasingly complicated EHRs is another factor. We're all getting away from the paper, and as a result of that, we're all having to use electronic records. The records, because of requirements by MIPS and the federal government, become complicated to a much higher extent, and that's a big problem. A lot of us older guys really don't like working with computers. The younger guys grow up with it, but I think there's still a lot of problems there. And then salary and payment issues. Mandatory pay cuts, this is a big problem. I can speak from experience of that. My brother was a hospitalist, and at the beginning of COVID, he was spending 12 hours gowned and gloved and working nonstop, and his hospital came to him and says, "We're cutting what we're paying you by 25%. And this is really a bad problem when you have when a doctor who's risking his life and was really doing everything he could, and he's told he has to take a pay cut or else he's going to get fired. Mandatory retirements is another thing. We have seen patients, or we've seen doctors who have been told by their medical system that at age 65 or at age 67, they are going to have to retire from their system. And so when you have a mandatory retirement and mandatory pay cut, it's not hard to think about leaving your practice. All that can do is help to make your burnout a whole lot worse too. This is a sort of a very strong explanation as to why people are not very happy in medicine. And you can see here, 25% of physicians are actually considering a switching career. And the number one reason for it is burnout. And so this is something that really needs to be addressed. It's a one that we really need to be trying to solve, because if we don't get it solved, there won't be anybody there to provide the care. One of the things that, there was a health affairs panel, and they were looking at workforce burnout last fall. And what they looked at was trying to find which factors are associated with a lower burnout rate. The first one was solo practices, doctors who were in independent practices where they were responsive to their patients, not to Mr. Hospital Administrator. The clinician in practices did very well as well. The third one is non-participation in accountable care organizations. We get pushed by our hospital systems to be part of ACOs, and unfortunately, these help to contribute to the burnout that we have in our practices. One thing that we know about healthcare administrators, and this is an interesting slide because we all get hit and deluged with how we need to be cutting costs in medicine. Well, one of the interesting things that's been shown, and this came out of the Bureau of Labor Statistics, that the percentage of growth in U.S. healthcare costs has gone up 2,300% between 1970 and 2019. Well, coincidentally, the number of administrators in healthcare has gone up at the same rate. Down here, this is the number of doctors has gone up, and you can see it's negligible compared to the number of hospital administrators. This is a major factor in here. If you compare to the U.S. to per capita cost of administration to Canada, the U.S. healthcare cost has about $2,000 per capita spent on administrative costs. Over 1/3 of total healthcare costs are due to administration costs. Contrast that to Canada, where it's less than $560. It's only $550 per capita, and it's only 17% of total healthcare costs. In other words, if we were able to reduce administrative costs in the United States to the level that it is in Canada, the healthcare costs would drop by $600 billion. So when you get that nice thing from United Health or OptumRx telling you how they're trying to cut money, physician, heal yourself, in my opinion, for them. What can be done to help this crisis? First of all, we need to have a multi-pronged approach. We need to obviously increase the physician training, not only in primary care, but in specialists. I think one of the biggest debates I've had when I've gone in Capitol Hill in Washington is primary care versus specialty care. And I explained to them it's not an issue of primary care versus specialty. It's actually an issue of cognitive care versus procedure care. We need to be working on trying to increase the number of people involved in cognitive care specialties, including primary care. We also need to find ways to decrease the physician losses. We need to first work on improve working conditions. And another thing is to improve the burnout problems, reduce burnout in our everyday practice. One question we've had is a lot of people say, oh, we've got a simple solution. We have nurse practitioners and PAs. And this is an interesting study that came out from the Journal of the Mississippi State Medical Association. And this is data from a Hattiesburg clinic ACO. And what they saw was that they looked at spending by provider type. And what they saw was that the non-physician providers averaged about $45 per patient per month higher in terms of, compared to the primary care physicians. And when they adjusted for complexity, there was about $120 per month higher per patient when it was the non-physician provider. Why is that? Number one, the non-physician providers ordered more tests, they made more referrals, and there were more emergency room visits than they were by the physician providers. So while we need the patients, help, they do need more care. The physician extenders are not a great solution when it comes to cutting cost and helping to solve all the problems there are in healthcare right now. That's an interesting question. We always hear people talking about, gee, we need to have the same system they have in Canada. And I started to look into this and I found this interesting study. And this actually was data that came out about a week ago. And what they saw that in Canada, there is a 44,000 physician shortfall, and 70% of the deficit will be primary care people by 2028. It's interesting that there are two provinces in Canada, Nova Scotia and Ontario, have made adjustments to how they license people. So that if a U.S. physician decides they want to move to Toronto because of the summer weather, they can get full licensure to board certified U.S. physicians very immediately. In the past, you had to do a 1-year limited license with supervision of certain exams and so forth. Now they're going to go, if you're board certified, they're going to go right and give you your medical license in both those provinces. They also have set up expedited work visa processes. And their big selling point is that, down in Canada, they don't have insurance pre-approvals and prior auths. It's much less of a hassle by them. The problem is they do have lower salaries. They have rationed care. Half of all people who need joint replacements are not getting them on the times they're recommended. Long waits for specialty care is a major issue in Canada, just as bad as it here is in the United States. One solution somebody raised was a 27-hour day. And what this group looked at was they saw how long does it take for a PCP to meet all the guidelines of preventive care, chronic disease, and acute disease care. And in a physician working alone, they saw that it takes about 14 hours of preventive care, 7 hours for chronic disease, 2 more for acute care, and 3.2 hours of documentation. I wish it was only 3 hours of documentation. What they found then is they found some solutions where if you have a team-based care, where you have a more extensive activity of your support staff within your office, that 27 hours can be whittled down to 9.3 hours a day. That's a whole lot better, but it still is pretty excessive in my opinion. One of the things we need to do is we really need to increase the number of trainees. And first thing we need to do is we need to get, right now, we have a problem where medical school graduates and IMGs, the number there are is higher than the number of residency spots. As I've already pointed out, maldistribution of the training position, there's lots more in the Northeast, and there are not enough in the South and the Southwest. And we also need to really focus more on cognitive specialty contributions. It's one of the interesting things we have in rheumatology gone to medical schools, and they say, well, rheumatology doesn't pay the bills because they only do cognitive care. A colleague of mine out in at Loma Linda, California, Christina Downey's group, looked at the price and how much was spent on a patient on a patient's care compared to how much money was spent by the directly paying the rheumatologist. And they saw that for every dollar that an academic rheumatologist bills, they actually generate $12 in revenue for their medical school. And that's because of a lot of things such as x-rays and labs and referrals to other specialists and so forth. So what it is we need to be educating our medical schools that cognitive specialties do contribute to the medical school, and they are definitely a worthwhile project to take on. The American Medical Association has done some innovation strategies because they are trying to help and realize all the problems we are facing in medicine. They have multiple approaches to try and improve physician well-being. There's a lot more engagement with health system leadership. We need to be talking to the health system leaders and tell them, guys, you are hurting your physicians. You can't provide care. They're the ones you need to provide the care. You guys need to be showing a little more respect to the physicians. Understanding burnout, ways to address it is another major factor. And then we need to develop a culture that actually supports physician well-being. We've all heard the jokes about the doctors who go off and play golf every Wednesday and things like that. Less than 15% of all doctors play golf, but that doesn't matter that everybody believes that that's a major issue in medicine. We need to find ways to show support and respect for physicians because we're the ones that provide the care. Tackling the EHR, and this is another major way to help. And there's some things we need to be doing. Number one, they want us to, the AMA is working to reduce unnecessary work by reducing some of the unnecessary rules. We all know what MIPS are. And we all have our lovely medical records and have to answer things, and we have to click this box and that box and so forth. This is unnecessary work. I've seen some of the most unusual ways to reach MIPS. One of the doctors in our area regularly asks his patients, have they been exposed to Ebola virus in the last 6 months? This is something that fulfills a check mark in MIPS, but does it really provide any better care? I don't think so. Implementing team-based care, finding ways to help utilize other staff members to enter data. In my office, I have a very invaluable medical assistant. She does a great job in getting some of the baseline data in. She gets it into there so that I already have some of the data that's needed for caring to my patient right there in the computer itself. And then improve proficiency using EHR. We need to make sure that the systems work and work for us and work for the patient. I think this is one issue where we get computer guys to come in and they think they know the right way to do things, but they never talk to physicians. I think this is where trying to improve proficiency. A little thing I've talked to our serving people is I ask them how many, this is only 4 more clicks is what they like to say. Well, it's only 5 more clicks. Well, I start that up. Okay, 5 clicks per patient. I see 20 patients a day. That's 100 clicks. That's 400 clicks a week. In a year, that's about 2,000 clicks. If each one takes 2 seconds to do, then you're talking about 4,000 seconds. That counts up pretty big, and that's starting to get to where you're talking an extra 10 to 12 hours a year, just in one issue that needs to be done. I have some pie in the sky ideas if I were the king of healthcare. First thing I would do is I would love to see changes in practices. I would like to see more physician leadership and autonomy in the hospital-based medical groups. Right now, we have these non-physicians telling us how to practice medicine. We get these things all the time from various groups saying that, they're told, oh, we want to help improve things, so you guys got to do it our way. Physicians need to have more input, and we need to be listened to. Second of all, I'd like to see improvement in the viability of private practices. Private practices still provide excellent care in a lot of areas. I think that this works well. It's lower stress levels. It's less burnout. And in the people who are in private practices, we need to find ways to keep them viable and strong. Next, reduce administrative burdens. We need to decrease the prior authorization hassles. We need to get rid of the insurance oversight. There is such ridiculous things. It doesn't help healthcare. All it does is make our lives more miserable. Reduce regulations that do nothing to improve healthcare. I think that's the one thing that helps a lot. Next, we need to have improved respective physicians by insurance companies and hospital systems. They claim in their commercials, oh, we're going to give you good healthcare. No, they're not. They cannot provide healthcare. It's the physicians that provide the healthcare. They need to be realizing this, that they can't do a thing without us. And the last one is modification of the facility fee payment program. One of the things that has helped to push the number of physicians that are bought out by the hospitals is that, and they're willing to pay lots of money to do this, is the recognition that if you are part of a hospital system and your office is part of that system, they get to charge an additional facility fee. Those monies do not go to the doctors. They go into the pocket of the hospital administration system, and that's not fair to do. I think that, I think the physician fee really is almost like a slap in the face to guys in private practice, because we still have the same costs and expenses. We don't get the extra fees that are given to the hospital system. All right, so now I want to get you guys involved in how are we going to solve this problem. I think it's important for us all to become actively involved in how we direct the changes that are needed to be done. I'm going to give you a few ideas on how to do this. First of all, we all should try and partner with patient groups, other provider groups, because there is strength in numbers. I have done a lot of things when I've gone to Capitol Hill with my patients. We've made Capitol Hill visits with patients, and we've done things with the Arthritis Foundation. The Arthritis Foundation really works good with us. And so I think that trying to work in conjunction with some of the patient groups that we have a lot of contact with makes a lot of sense. Second, become a voice. all of us need to start trying to reach out and become more vocal about the healthcare issues. Writing letters to the editor of our local newspaper, op-ed pieces, media interviews. These are some of the things that can help get the word out to about physicians and what we are facing. It's interesting. There are patients looking. There are people that are actually looking for representatives of organized medicine, and what happens is you have a chance to shape the dialogue. My national organization has a list of rheumatologists that are available to speak to reporters. I've spoken to reporters probably half a dozen times already this year. And it's sort of cool when your patient comes in and says, hey, I saw what you said on creaky joints. What a neat thing. Volunteering in your state society. We all look at the state societies, and Tennessee Medical Society, TMA is up in Nashville. We have a lot of other organizations that are around. Volunteering and being a part of that group helps you to work with others so you can see what can be done. And even getting involved in your local medical society. In my area, one of the things we have every December is we have a dinner with our local state and federal representatives. We have a chance to have dinner with them. We have a chance to discuss issues with them and talk to them. And it's really been a good thing because that's helped really spur a lot of new ideas on how to manage some diseases. Another thing is, the one thing is medical societies, they can really help a lot. They have a lot more resources. They have professional lobbyists, and they will represent all the interest in medicine in your state. The one problem is that, in a small specialty, you may not be a big focus, but there are times when your state representatives and your state societies do listen to us guys in the small trenches and work hard. Fortunately, in Tennessee, we have one of my colleagues from Chattanooga is now on the board of the Tennessee Medical Association. Another thing is get your colleagues to be involved. We all need to be stepping up. We all need to be actively involved. And that's an important thing. Another area that I've discovered as a problem is getting academic leaders to be involved. One of the problems is I've been told by some of my academic colleagues, oh, we don't want to be part of that because it's sort of sully to be part of that advocacy stuff, that politics stuff. We're in academia. We are above being a politician. Unfortunately, politics is not beneath any of us. And the more we get involved, we have to do that. Our academic leaders are very good because they have the name, they have the reputation of being at the big medical center. And I think that helps. And finally, giving to a medical-based PAC. Political action committees, some people think they're sully and dirty and everything else. Unfortunately, we are facing where political action committees are developed by pharma and by insurance companies. United Health spends about $6 million a year in Washington, D.C. doing political activities. They have 6 different lobbying groups. Contrast that, the American College of Rheumatology raises $150,000 in our PAC. So we are facing much lower amounts of money. The benefit we have is when we go up there, we're talking about our patients. We're not talking about our pockets. And I think that's an important thing. That's why we really need to be getting involved in the medical-based PACs. There are some solutions that have been tried for helping with the workforce. And one of the things we have is, you can see here, these are some bills that have been out. The Resident Physician Shortage Reduction Act, unfortunately, it went pretty well nowhere in 2022. And what this does is this would lift the cap on the number of Medicare-funded GME positions. And the thing is, this is very important. It's actually looking like it may make some progress this year. The Resident Education Deferred Interest Act. When I was a resident, we used to be able to defer our interest on our student loans until the end of our residency program. There was a nice senator up in Massachusetts who pushed to get that changed. And so everybody who comes out of medical school starts to have to pay interest, at least on their residency, on all their loans immediately after medical school. The Conrad State 30 and Physician Access Act, this is one that's just been resubmitted in Washington for this Congress. And what it does, it allows in the foreign grads who stay in the United States after residency if they practice in areas with shortages. So if you have somebody who's an IMG to come in from Europe or Mexico or South America, they do their residency. If they agree to go to areas with shortages, they may be able to stay there, and that'll help with the manpower shortage. And then the Specialty Physicians Advancing Rural Care Act. This is one that it authorizes HHS to get qualified specialists part of their loans repaid. This is particularly involved for us in pediatric rheumatology. Right now, there are 8 states in the United States that have 0 pediatric rheumatologists. Another half dozen or so have only 1. And so when kids, there are 250,000 kids in the United States that have pediatric arthritic disease. And there's a shortage of those doctors that know how to really care for those patients. And if they have someone, they may have to drive 6-10 hours just to see a doctor who knows what they're doing with these diseases. This will help with them. If we can get the pediatric residents to have their loans repaid, they may be willing to go into rheumatology and then go to a rural area that needs the shortage. Reimbursement education legislation. This is one that goes to those of us who got the 3% pay cut in January. I guess physicians are the only people in the United States that are completely exempt from inflation in this country. Everybody else has seen 8% inflation, but since the government thinks we can take a 3% pay cut, they must think we're exempt from that inflation. Well, anyway, the first one that happened was Supporting Medicare Provider Act, and this is one that they had back in 2022. This is one that was bipartisan. It had 115 co-sponsors, but it never went anywhere because it was not one of House Speaker Pelosi's pet projects. Strengthening Medicare for patients and providers. This is a new bill. It's a bipartisan bill. 4 congressmen sponsors who are doctors have helped actually come together. And what this would do is this will reform the outdated Medicare payment system. It will get rid of the doc fix needs and things like that. And they're going to come up with a more rational way to set pricing for Medicare so that it's fair and it recognizes that inflation occurs even in my private practice. This is another one that came out that was in last year's Congress, but has not been yet dropped in the current Congress, was increasing access to osteoporosis testing. We know that they, about 10-15 years ago, they dropped what they were paying to 1/3 of what it is. And now the reimbursement is less than the cost of the machine. So this would start to recognize, and what's interesting is within 5 years of that happening, the number of hip fractures went up appreciably. Well, they're starting to realize that there's more osteoporosis now, and we're not getting the testing that we need. This will help make it more financially available. All right, one of the issues about getting a bill passed, and this is something I've learned having been up to Capitol Hill. First of all, it may take several sessions to get a bill passed. They put out a bill this year and they may get a few people looking at it, but then by the end of the Congress, it's time to go with the new Congress. So they resubmit it, and this time they may get a lot more interest and then a lot more. It may take 2 or 3 different Congresses to get a bill passed. Second of all, it's hard to get through one side of Capitol Hill if there's no companion bill. So as you saw, there were some bills I mentioned that have been submitted on the Senate side. Unfortunately, they don't have a House sponsor that's submitted it on the other side of Congress, and so this really makes it hard. If we can get people to submit a bill on both sides of the Congress of the Capitol, it has a much better chance of getting finished. We also need lots of co-sponsors. The more co-sponsors there are, the better. This is where we all come in play. What we need to do is, if there's a couple of bills that you see that really need to be, you really want to get passed, you need to be contacting your congressman or your senator and say, hey, this is a bill we're asking for you to please co-sponsor. If we could get 150 co-sponsors on a bill in the House, it has a really good chance of being passed. Another thing is it has to have bipartisan support. Right now, we have a House that's Republican, we have a Senate that's Democrat. And the problem we have is, so we need to have bipartisan support for a bill to be passed. You're going to have to get Democrats and Republicans to actually talk and work together on some of these things. Last but not least, it needs to be liked by the leadership to be brought to a vote. There are a number of bills that have come up and had 100 sponsors, but unfortunately, if the Speaker of the House doesn't like the bill, it's never going to be brought for a vote on the House or on the Senate. And so this is one big problem. We need to find ways to get to our the leadership and say, please pass this bill. We need this bill. This is particularly important in people who are living in where the Senate and House leaders are. Kentucky is a pretty important state because of the fact that's where the Senate minority leader is. We're not in New York, and so that's a big problem with getting the Senate majority leader. But it's one thing that we can do is if we know someone in the House or leadership, getting them to really step up is an important thing. Louisiana right now, because of one of their congressmen, who's one of the leaderships, Stephen Scalise, that will be a big person. And that's one, if you know him, start talking to him about getting some help to get these things done. All right, how to be an active advocate. I think this is a little bit more. I've already said a lot of this, but I'm going to repeat it. First, sending emails to your senators and your representatives. You can either compose your own, or you can go to your medical organization's advocacy site, because they've got letters there that you can send. You can actually go in and personalize it to say, this is me and I'm saying this. The interesting thing is, if you go to a senator or a House of Representatives office, they have people there that all they do all day is work on social media and things like that. They count every single email that is received by that congressman. And I'll tell you right now, I've actually gotten personal emails in reply to letters I've sent to my senators and to my reps. Number two, make a phone call to the DC office or in the district. Again, when you make a phone call and say, hi, I'm Dr. Joe Smith. I'm in your Senate district or in your House district. I really feel strongly about HR. Know the name of the bill, which is the name and the number. It's like HR 4243, something like that. What you do is you can say, I am a big supporter of this. Please have Congressman Smith think about it. Visit your representative. There are two ways you can do that. You can go to Capitol Hill, or you can visit the district offices. When the Senate and the House are not in session, most of the representatives will have some office time in your district. What you do is call their office, find out when they're going to be in, and just make an appointment to come talk to them. Attend fundraising get-togethers. If you are there and you're presenting a campaign, if you like your senator or your congressman and you really want to give some money to their donation, find out when they're going to have a small meeting, and you can give the check to those people, and you can get some good FaceTime with the senator or representative. One of the things that's sort of neat we've discovered is that when we go up to Capitol Hill, these small meetings that they have, the congressmen and the senators know everybody that's in there because they see these lobbyists all the time. When you're in there, they'll look at you and say, I don't know that person. Let's go talk to him, because they know the story that's going to come out of the lobbyist. They don't know the story that's going to come out of you. So you can find yourself having a lot of FaceTime with your U.S. representative or with your senator. This is a big thing, visiting Capitol Hill. This is a picture of me with my daughter a few years ago. And this, she came along for a May Capitol Hill visit. She's a sophomore in college, and one of the things we did was we got to go into the Senate office buildings, visit with our Senate legislative aides. We then walked across the Capitol Hill, which we're getting ready to do in this picture. And I will tell you right now, I know it looks fake, but that is really the U.S. Capitol. And that picture is in my daughter's her little study area, and it's really a neat thing to do this. It's really awe-inspiring. We go there, we see it on TV, but when you go in there and have a chance to talk to them in real life, they're there to listen to you because they are our hired help. And that's why we need to be stepping up and really going at this. All right, the biggest thing is we are more knowledgeable about our issues than the people on Capitol Hill. There is a term that's used for non-government experts on a subject, and that's called a wonk. And if you are a wonk for your congressman or senator, that means they're calling you to find information on a topic, and you can really give them a lot of education related to that. The word doctor is derived from the Latin word docere, which is to teach. We need to be teaching our senators and representatives about things that we are dealing with and let them know where things stand. Don't assume that they know a lot about our issues. One of the things is you have to really speak to them in English, not medicalese. The other thing is you have to be patient. You have to explain things that, that may take a little time to be explained. A great example of this, I walked into a congressman's office who was on the Senate, let's see, he's on the Senate committee that oversaw Medicare and Medicaid. I talked to his legislative aide who introduced himself as his healthcare point man. And he says, what can I do for you? And I said, well, I'm a rheumatologist. I got a blank stare. And that was like, good God. And then I had to explain cognitive versus procedure care. He did not understand these things. So they really don't know all that much about healthcare issues. They really, are really learning on the job. And so you might need to explain things that we think is second nature or common knowledge and really explain it so they understand it. Now, one thing you need to realize they may have some skepticism about our viewpoint. One of the things I was told by one legislative aide is when they go into a room, and meeting somebody who's talking about an issue, they say, okay, what lies are they saying to us? Being honest, being truthful, being understanding lets them see that we're there in earnest. We're not there trying to pull their leg and work out for us. We're working out for our patients. It's important to do this because insurance companies, PBMs, attorneys, and pharma all provide their side of the story. So we need to present our side. And that's a very important thing to keep in mind. If we aren't speaking for ourselves, nobody else is. I think getting involved, you can do this where you live. You don't have to go to Capitol Hill. You can go to the state capitol. You can meet in the community, as I've done, contact your legislatures, and then the state advocacy guide. If you call your state society, they've got an advocacy guide. And this gives you tips on a successful advocacy, how to schedule a meeting, sample meeting request email, and thank yous things. It really does make a difference. I was amazed when I talked to a guy on Zoom for a couple of years. And when I was up there in real life, he comes up, God, it's good to see you. So you can make a good friendship and working relationship with guys that are on Capitol Hill. I think I'm going to finish with two big quotes. And the first one is attributed to Edmund Burke. And it's important to realize the only thing necessary for the triumph of evil is that good men do nothing. That's a very important point because we need to do the good, because we're the good people when it comes to healthcare, and we need to be stepping up so we can, keep evil under control. Finally, this is a quote that comes from rheumatology. I don't know who said it originally, but it's said all the time. If you're not at the table, you're on the menu. And that is a truism when it comes to advocacy. So basically, we have a choice. We can either fight or we can give up. And I think if we start going and fighting a little bit, we can work through each other, trying to give advice on how to help, tips on way to go, assistance. There's a whole different ways that we have available to help us toward being good advocates. Conclusions I have made, these are my personal ones. Number one, the physician shortage is a real entity. It is a problem that unfortunately has probably been contributed to many times of us shooting ourselves in the foot. The biggest problem is there are many causative factors, and the people that have acknowledged that they will never be acknowledged by the people that are responsible. This is the biggest problem of all, is we have people that, they won't admit they make a mistake. In Capitol Hill, the running joke is they don't make mistakes. They have negative unintended consequences. And that's the truth. We need to realize there are people up there who think they have, they have these problems, and they say, it's not my problem. I didn't do it, when they really did. And finally, we all need to step up, and we all need to help solve this crisis that we're all facing in medicine.